going to bring up Dr. Shoma Stout to give the keynote address today here at our Flip or Flop event. Dr. Shoma Stout.
It is such a privilege to be here with all of you at Flip or Flop. Now, we have people on the radio who are listening, so I will just briefly introduce myself again. So all of you, don't think I'm crazy, since I've already been with you this morning. But so I'm Shoma Stout. I am a primary care doctor, and I've been working in the safety net of the US, working in community health centers for the last 15 years, and I've been working in global community and public health for the last 20 years, working in some of the places that from the outside look like communities of poverty, who I've watched make some of the most transformative changes in their health and well-being in incredibly short periods of time, that I describe as communities of solution. And as I've been learning from these communities that have been able to make these kinds of transformative changes, I've realized that they begin to act and think in certain ways that are different. And I hope that to share some of those stories with you today, because I think that those are the kinds of stories that are needed to create change in the world. I've also had the privilege, I work at the Institute for Healthcare Improvement and at Harvard Medical School. And because of that, I now get to travel all around the world and all around the country to think about what it takes to create health, well-being, and equity. I lead the 100 Million Healthier Lives Initiative, and we have over 1,000 communities and members that are working together who reach hundreds of millions of people in the country that they've said, we're in to try to improve the health and well-being of this place. And Kershaw, one of our Pathway to Pacesetter communities, is one of those places that's learning what it takes to create health, well-being, and equity. And I'm so privileged to be here in Kershaw, learning how you are creating healthier lives and a healthier community right here. I think that our goal is to connect the efforts of learning of the places of the kinds of change you're creating in Kershaw with communities all around the world. Because we don't have to be isolated. Every community is different, but every community isn't terminally unique. All around the country, we have the same kinds of challenges. And it's as we learn how to create interconnectedness among all of the groups, all of the things that are needed to create health and well-being, as we look at how we redesign from the person and population and place up, together we have a much better chance of figuring out what it takes to create health, well-being, and equity. I'm going to start today by sharing just a glimpse of one of the first places I learned about creating change, and that's the Rupununi region of Guyana. Anybody ever been there before? So the Rupununi region of Guyana is actually the second poorest region, and at the time was the second poorest country in the Western Hemisphere. It's a rural region, about 16,000 people in 33,000 square miles. Can you imagine that? One person for every 2 square miles. There are no roads at the time, some dirt roads that were there, no paved roads. They didn't have a communication system in place. They too said the first thing we need to do is get to communicate with one another, to get connected. And for them, their first step was having long wave radios where they could at least communicate with one another. No electricity. They had only up to a 5th grade education at this school. So they had a 0% high school graduation rate, just by definition, because they just didn't have people who could go past the 5th grade. What that meant was that the teachers in the schools were people who'd gone to the 5th grade and then were going back to teach the rest of the people for generations. So imagine what that does in an education system over time. And it was a subsistence economy. People lived by farming, did the best they could by farming, and whatever they made was what they were able to do. It was in the Rupununi region of Guyana that we began to learn what it takes to unlock the trapped and untapped potential in communities. And when we do that, what's possible? It was working with Varka Foundation, which was a nonprofit who saw that the way that you create change in communities isn't by having a set of things that you know one needs to do and just come in and say, look, if you all just did this, everything would be better. And it's not that they withhold that information. When the community wanted that kind of information, they made that information easily available. They helped them. When there was a blind spot, they would share that as a blind spot. But what they saw their role was to think about how to accompany this community. They believed firmly that this community had what it needed to create health, well-being, and equity. And they saw that their role was to help, to walk alongside them and unlock their capability and their confidence to lead that process for themselves. As they began to do that, we began to find some of the most remarkable change leaders. Now, this is Eugene McCabe. He's only had up to a 5th grade formal education, but he's one of the most outstanding improvers that I've had the privilege to meet around the world. Now, initially, they began doing simple things there. They got that long-wave radio communication going. They had a small hospital with 8 beds in it, but there was no sterilization of equipment, no blood bank, things like, imagine that. So they got the basics started. But then they realized no one could make it to the hospital. So they said, it took 8 hours by bullock cart to make it to the hospital. So then they began to think about going out into the community. They got a small grant, got a Land Rover, and began going out into the community. And they did that and began to get many more people care. But they realized they couldn't do that very long, and it wasn't very sustainable. So they had community health workers in each community, each of whom, there were 36 of them, they had been given 3 months of education to take care of their communities. And then they were just out there isolated alone. So they began building up the skills, the talents, the knowledge of the community health workers to care for their community. And things began to change. And after a little while, they began to see that these community health workers, they formed teams of community health workers, villagers, and teachers who are responsible for the health of their community. And together, they began creating creative solutions. They learned how to assess their community, to get data, just like Holly presented to you. It wasn't sophisticated, but it was actually quite valuable. They learned household by household. They walked around and they understood what was going on in every household. And they began learning how to look at that and to how to create some possibilities for what could be improved, trying it out and measuring to see what could be improved. And as they did that, they began to create breakthrough outcomes. This is a community health worker who figured out how to eliminate acquired developmental delay in kids 0 to 4. Eliminate it. What was happening was that women were actually going out into the fields to farm. You needed to have 2 people farming in order to make it. So the baby would go on the back and they would be out and farming. So the kid would be born fine, but they wouldn't have enough interaction with them. Now, he also knew that actually a woman's literacy was the most important predictor of whether that child would live past the age of 5. And knowing that, what he decided to do was to start nursery schools where mothers and kids would learn how to interact with their babies, even if they were going out, how to use the simple tools and methods like puppets, etc., to be able to help support that. By doing such a simple thing, he actually increased the literacy level of the mothers and changed the way that mothers played with kids. I know that sounds like not a very complicated thing to do, but had a profound impact. Another community health worker figured out how to reduce malaria rates by 90% in a year, while at the same time eliminating malnutrition among widows. What he had the ability to do that no one from the outside could ever have managed to do was that he looked at his data, he noticed that there were widows who, as a single person working a farm, you couldn't make it. You just didn't raise enough food to be able to make it through the winter. So they'd get malnourished in the winter. And he knew that the villagers needed mosquito nets. Everybody knew that mosquito nets help prevent you from getting malaria, and 80% of people would get malaria every year. So it was a big problem. What he was able to do was to actually convince the widows to stop farming, to form a sewing cooperative, and to weave mosquito nets that they could exchange with the villagers who couldn't afford the mosquito nets, but they would exchange it for food. And by doing a simple thing that looked at deficiencies as assets, as thinking in asking creative ways of how could we use things differently, but also a person who had trust in their community, who knew their community well enough to really understand what those levers could be, and who people would trust well enough to actually give up farming. Think about that. That's not something you do when someone just comes in who you've never met before, says, I'd like you to do this, and you do that. It takes somebody that you really know and trust to be able to help you do that. And these are the kinds of changes, I could tell you stories all day long about what they were able to do. But I think this convinced me, after watching this happen over 10 years, where within 10 years, this region was raising its own doctors, nurses, midwives. They realized after a while that the structural thing they needed to change was education if they were going to have health. And so they all invested together in staffing and supporting a high school for the whole region. Now they have 2 high schools with a strong science track that grow its own doctors, nurse midwives, increased training for community health workers, et cetera. That was really important because before that, the government would need to send somebody every year to this region to run the health system who never understood the region and didn't know how to create change and would leave after the year. And that they couldn't actually create sustainable change if they didn't do that. Now, what were I shared with you some of the ideas and principles. What did you all hear in this story that you think might be relevant about what created change? What enabled them to create change? Trust. What else? Communication. Bartering. What else? Awareness of your environment. What else? Knowing their individual community. What else? That the solutions were in the community. Data. Thinking outside the box. Initiative. A belief that it was theirs to do. You know, I was a graduate student at the time that I went here. And one of the things that I was asking people is, you know, do you think health is a human right? And 100% of people in this that I interviewed, 100% believed that health was a human right. And I asked them, well, what does health mean to you? And they said, oh, it's complete mental, physical, social, and spiritual well-being. And I started sweating a little bit. I was like, how on earth does a community that's at or below the subsistence level do that? How does someone provide that? And so I asked them, how do you think that happens? And they said it's our responsibility to create that for one another. And it's in that ownership that it's our job as a community to provide that for each other and to get the supports that's needed from others that they began to create the environment for their own abundance. So I just invite you to think about that. So these are some of those principles. They went from a me to a we. They went from isolation in these villages to interconnectedness. When one community health worker would figure out how to solve a problem, they didn't say, oh, that's over in that village. That's not going to be good here. They just tried it in the other villages. That's how they could eliminate acquired developmental delay across the entire region. They went from pathology, look at all the things that are bad, and they were in a state of pathology at the beginning, all the things we don't have, roads, electricity, et cetera, to vision. What would be a vision for a healthy community here? I hear that you've been building a vision right here in Kershaw. They went from scarcity thinking to abundance thinking. We have what we need, mostly. We may need a few other things, but let's take advantage of what the abundance we already have to create the changes. They went from having answers to having questions, just like Holly pointed out this morning. From perfect planning to learning and failing forward. To being able to say, you know what, we're going to try it, we're going to see if it works, and if it doesn't, we're going to see that fail as the first attempt in learning. They went from embracing system transformation. And what I mean by that is, I remember actually so I was the one who pointed out to them that unless you have an education system, it's going to be really hard. And I have to tell you, I said that to them with a pit in my stomach. Like, how do you tell a group of people that are so wonderful and motivated that they have this big system barrier in place that feels overwhelming to address? We don't have past a 5th grade education system. They started the next week to think about how they were going to fix that. It was utterly practical from their perspective. Oh, that's the problem? We can figure out how to solve this. And we are going to figure out together what it takes to do that. This interrelationship between the health and well-being of people, the different groups of people, the widows, the places, what does it look like to have a system, a place that doesn't have certain things, and what are its assets, and the systems of society. Do you have, for instance, an education system that reaches everybody is crucial. Since then, I've spent all my career trying to learn whether these principles that we learned right in Guyana, in the second poorest region, in the second poorest country in the Western Hemisphere, applied in other places. I came to Harvard Medical School and I ended up starting a community health center and eventually became the vice president leading the transformation of the entire Harvard health system. Every one of those principles has applied, and what we've done since then is learn who has the tools, like the model for improvement or other things like that, that help us learn and think in a different way. And so I'm here really because of what I learned in a tiny rural country somewhere. And that's changed the course of my career because those principles are necessary everywhere if we're going to create change in a fundamentally different way, I believe. We have some problems to deal with. And so I'm going to invite you today to think with me about how we address these problems. We have a country where already 30% of median income is spent on healthcare. That means that 1 out of 3, a third of every dollar that the average family takes home is spent on healthcare. On the bottom, see that red line? That's the US. We're winning there. Do you know what we're winning? It's the race to obesity. We are on track to be the most obese country in the, by far. We are winning that race. There's no one else who's even close. It's just not the race we want to win. And the problem between those two things is obesity causes diabetes, which causes chronic disease, which causes a whole bunch of other problems in terms of health outcomes and healthcare cost. And so what you see is a balance in policymakers on a razor thin of the dollar to say, where am I going to spend my money in? What are we going to spend our money in as a country? Are we going to get our roads better, build the transportation systems that are needed in places like I heard transportation come up a whole bunch of times in our conversation. Or are we going to be able to keep people in the hospital? Are we going to solve our energy crisis? What are we going to do, and how are we going to be able to do it? It's a trade-off. And we need to, everyone, whether you're in healthcare or not, need to become invested in the problem because it is your problem too. At the Institute for Healthcare Improvement, we began to think about what we as a healthcare system can do to address this problem about 8 years ago. We created something called a triple aim and engaged hospitals and communities to begin to think, how could we improve the experience of care, the health of the population, and reduce the cost of healthcare at the same time. And we began to learn a lot about what it took. 100 million healthier lives grew out of that effort to understand, because what we saw was that people took that journey on, but almost everybody stayed in their silo. Healthcare kept doing what healthcare could do, and public health kept doing what public health could do, and community-based organizations kept doing what they could do. Do you know why that was? Can you imagine why that might have been? No relationship. So you can have communication, but if you didn't have relationship and you didn't know how to begin to work together, you never know, oh, this is how we could all begin to put our pieces of the puzzle together. And that's what 100 million healthier lives is really designed to solve. The second thing that we learned is this. So I was a vice president at this time leading transformation at Cambridge Health Alliance. And we began working on our people with diabetes to see how we could get to be good at diabetes and chronic disease like you guys are at Kershaw. And see that we optimized medical care, we created relationships with people, we did everything we could within the walls of our healthcare system. And we did a good job. It was named by Health and Human Services nationally as one of the 4 innovative and effective transformations in the country. And that blue line down there, that's a 36% reduction in our hospitalization rate for people with diabetes. That's really good, right? Here's the problem. See that red line? It has a number of people who got diabetes during the same time. Now, some of that was because we had expanded Medicaid, so we had 1/3 more people that we were taking care of, so that we didn't care about that. But the rest, it was a doubling. And that the problem with that is because if you start treating diabetes after the fact, if you don't start downstream, if you don't start thinking upstream of where obesity is created, you lose the game, even if you're doing the best possible redesign of healthcare. Healthcare, even at its best effort, cannot win this game alone. And that's why healthcare needs the help of every other sector that cares about health and well-being of its people. And we began to see that what was happening, what we'd noticed in the US at Cambridge Health Alliance wasn't just a local problem. Right now, we spend $322 billion as a country on diabetes and pre-diabetes. 111 million Americans, 1 in 3 people, have pre-diabetes or diabetes. Did you know that? Do you know how much we're going to spend on pre-diabetes and diabetes projected based on the American Diabetes Association by 2020? What would you guess?
More than billions.
So $322 billion today. What do you pick a number? What do you think it will be? 700? 550? Holly wins the game. It's about 520. So it's about somewhere between 520, $550 billion. What would you do if you had another, I don't know, $200 billion or so? What could you do with that money? I can think of better things to do than just to put it in managing more pre-diabetes and diabetes. The problem is, it's going to come down to a choice of whether we're investing in more dollars for treating people after they're sick, or whether we're going to invest that money in prevention. But frankly, that money isn't going to be available for schools, for public health departments, for fire departments, for police, for any other reason that we might wish to spend money on. Here's the really bad news. It turns out that these problems that we'd been treating, sort of chronic disease over here, and we'd been thinking about our efforts in social services over here, it turns out that those two things are fundamentally, almost certainly interconnected. They've been doing studies which show that the exposure to toxic stress of a child growing up between the ages of 0 and 5 in a household where there's stress gives you a 40-fold higher risk of developing a chronic disease by the time you're 40 or 50. Everything I can do in my primary care office with the best possible systems might reduce your risk by 2-fold. It's like we're trying to put out a fire while there's a tanker of gasoline going into it at the same time, and we've got buckets. It's not going to work if we aren't able to think differently about the problem. See these two maps? This is just about correlation, but how do these two maps look to you? They look the same, right?
Yeah.
Pretty similar.
Yeah.
On the left-hand side is a map of economic hardship, of people in poverty. On the right-hand side is childhood obesity. We're growing the chronic disease problem right in front of our eyes. And we can continue to try to think that physical health and social well-being are not interconnected, but all the data is telling us otherwise. And we can just keep hoping. We're already spending twice as much on healthcare as any other developed country in the world. Or we can think differently about how we interconnect these systems and think in a different way about what investing upstream really looks like and where we need to invest if we want to go upstream. The other thing that I want to share is that, when you start digging into the problem, you realize that there's actually systems in place that propagate the inequities. And in a way, Holly got into it a little bit with the data. You begin to see, one thing that started, that there's poverty, and then there's less money, there's less of a tax base, right? And then when you have less of a tax base, you have less money to invest in the schools, so you have less people growing up and graduating and thriving from the schools, so you have fewer people who are contributing to that tax base. That's a system. All these gears are things that are set up that propagate and keep a system in place. Here, this is, for instance, in some communities, there's redlining that looked at whether banks were trying to figure out where it was safer to invest. But that created communities of concentrated poverty. And these kinds of systems are there in the background, often created by some well-intentioned people, sometimes not necessarily, but they're there. And if we can't recognize that they're there, that there are these gears, these systems are in place, and they're continuing to create inequity in terms of our health outcomes, we're not going to be able to take those down. We're going to be able to try to catch people at the end of that system and try to fix them back up. But really, we need to think upstream all the way to understanding the systems and policies and procedures that are in place that keep producing those poor health outcomes. We need to think all the way upstream to our root causes. The health and well-being of people, the health and well-being of places, and the health and well-being of systems of society. That's what we have to learn how to take on together. This is a crucial moment in time. Do you know what 20% by 2020 means? Who can guess what that number is? What's 20% by 2020? I already told you at lunch, so you can't answer. All right. What's 20% by 2020? Take a guess. Yes?
I would say that means we're only going to spend 20% of our money on the 20% of the healthcare determinant, the clinical part. The other 80% is going to be spent on the other 80%.
Pretty close. That's right. So it's a 20%. It's a 20% of our gross domestic product that we will spend on healthcare. That's right.
I have no Ivy either. No Ivy on that.
It's excellent. So imagine that every healthcare dollar spent in this country, that everything we produce, 20% of our gross domestic product spent in one sector. By 2064, it will be 100%. Anybody want to spend all the dollars we have on healthcare? Anybody think that's a good idea? I'm a doctor. I don't think that's a good idea. So we have a problem that we have to solve together. Do you know what 80% by 2020 is? So 80% by 2020 is the number of healthcare dollars for Medicaid and Medicare that will change in the way it's paid between now and 2020. So that instead of getting paid right now, where no matter what you need, I get paid to help you with that, it'll become a global payment. That means that suddenly all of the healthcare systems will have some incentive to try to keep you as healthy as possible. That's a good thing, but we need to invest in thinking about how we change what we're doing to take advantage of that. That was created to help us recognizing this cliff that we're going toward in terms of healthcare cost. But let's think differently about what we need to do then to make that better. So on the journey to population health, we say that there are 5 key shifts we need to make. Right now, we have a sick care system. And we need to go from that, from a healthcare system to a health and well-being system. That takes all those groups that you saw were needed to help those 6 people that you became for a short time, where that creates a health and well-being system together. We need to take our work on equity from doing good or social justice. Not that it isn't doing good or social justice, it is, but we need to see it as actually critical for us to do in order to improve both health outcomes and healthcare cost. It needs to become everyone's job. We need to move from scarcity thinking to abundance thinking. Because in a moment where you're thinking, oh my God, all the money's going away and what are we gonna do and how are we gonna do it? We can't afford to be in scarcity thinking. It'll actually worsen the problem. We need to be like those community health workers, villagers, and teachers in Guyana that said, this is our problem, and we have what we need to solve it. We need to shift from pathology to vision. So we need to believe that change is possible and begin to create a vision for what that change looks like and think how we can make it happen. And we need everywhere to think about how we shift communities of poverty to communities of solution. 100 Million Healthier Lives was created as a challenge and an invitation for communities all across the country that were willing to do this, to try those 5 things, to come on board and to learn together what it takes to get there. We proposed that if we were successful, we could have 100 million people globally live healthier lives by 2020. We said to do that, we need unprecedented collaboration. We need to take a humble and innovative spirit of learning and improvement, and we need to be just as practical as they were in Guyana about system transformation to get there. Kristen Lind, you've seen again, those domains of mental, physical, social, and spiritual well-being, and a process that build the confidence and capacity of people and places in how to create health and well-being within their community and for one another has been fundamental to our approach. And what we've said is that to do this, to sort of lead from abundance, we need to think about how we lead from within, how we lead together, how we lead for outcomes, and how we lead for equity together. At Cambridge Health Alliance, where we adopted this kind of thinking, that Harvard Health System that I was showing you, we flipped our financing model. We went to payer by payer and changed the way we were paid, and then began to invest in the things that were needed. Within 2 years, we were able to remove 10% of the cost of healthcare. 10%, that's a huge amount of money, and reinvest that into the things that were needed to create health and well-being in our communities. What could you do with $200 billion extra dollars? Because that's really what this journey is all about. It gives you abundance if we can think differently. Leading from within, leading together, leading for outcomes, and leading for equity. We're going to show some examples of what that looks like. So all around the country, people are coming together to figure out what that is. On the left-hand side corner is Two Lakes Elementary School. Now, often we think of places and people that are able to succeed and those that aren't. But in Oklahoma City, Two Lakes Elementary School has figured out how to help kids learn how to apply improvement thinking to their own education. Rather than giving kids the grades, the kids assess themselves and think about how they might need to improve. They've gotten Black minority kids from poor families to the 65th achievement level as an average across the board. It's a remarkable accomplishment. They've also trained up their teachers in things about implicit bias and structural racism. And so they've created a community around these kids that see them as children, not of children of poverty, but as children of possibility. And that's created in these children a belief in their own possibility and a belief in their own achievement and a willingness to fail forward as a joyful thing for how kids learn. On the right-hand side is my friend Ashley Atkinson. Now, Ashley looked around at her community of Detroit, and you might have heard that Detroit has hit some hard times recently. Lots of automotive industry jobs the industry has left and the jobs have left alongside it. She looked around at all these abandoned lots that were filled with beer bottles and glass and that really sort of brought a community down, it depressed a community, and said that is an opportunity for abundance. She began working with others to reclaim these lots and invited those around them to become urban farmers. 8% of Detroiters are now urban farmers, growing the fresh fruits and vegetables that they need. Their goal is food sovereignty in Detroit, growing all of their fresh fruits and vegetables, at least 51% of them by 2030. They already have 8% of people of the way there. What's interesting, of course, is that the urban farmers are happier. When you look at their health outcomes, they weigh less, they've lost weight, they've begun to exercise more, but they've begun to build community with one another as they've come together. Sometimes the things that we look at that look like the things that make us weak can be the things that make us strong. On the bottom left-hand side is UTech in Massachusetts. Now, in Massachusetts, we have a problem with gangs. You probably don't have that problem here. Do you? Oh. Okay then. See, we're not so different after all. In UTEC, they looked at former gang members as the assets. And they said, what if we could get the people who are former shot callers in gangs, the people who had risen in leadership? We saw them as youth who have leadership capability. And we instead said, hey, you see that all the kids after you, they don't live very long. Would you consider a different way? They became street outreach workers and began working to engage other youth around them. They formed partnerships with their local hospitals so that when someone ended up in the emergency room or with the police departments, they called UTEC first, rather than just throwing the kid in jail. And then as youth began making that decision, for 6 years they began supporting them to live a new life. These kids now, they were able to go from 60% of these youth getting reincarcerated, 60% got reincarcerated before, to 2%, and have sustained that. And think about that. It costs, think about the change in the life of that child. These kids have learned how to work in business. They learn employment skills. They get their GEDs and finish high school. And they become leaders, trained as leaders in their community. What a difference. That's a life-changing impact in terms of health and well-being. It's not, when you create health and well-being in this whole kind of way, it doesn't just help the health sector, it helps everybody. The cost of incarcerating a youth in Massachusetts, $53,000 a year. It's about the equivalent of going to an Ivy League school. The cost of actually thinking about having a UTEC, $25,000 a year for that 6 years. But if you get reincarcerated, you get reincarcerated for up to 20 years. Would you rather pay for a college education or a prison cell?
Yeah, education.
In Palo Alto, they had many people who were older. And you know, what they found was that social isolation, that elderly people being isolated, was the largest contributor to their poor health outcomes. They looked at their data, and that's what they saw. And so they thought, well, what's the resource? And first they thought, maybe we have people visit them. But the people who end up volunteering to visit elderly, those are rarely sustainable changes, you know, because they depend on actually a volunteer workforce that's often very busy. Instead, they said, well, what if the seniors themselves became the assets? So these seniors, they created a time bank. People who are working created problems that they needed help with. It could be anything from, I have all these pictures, it's like, this is my problem. All these pictures I've been meaning to put up and I've never put them up, to I hate cleaning, to whatever that is. And the seniors began to volunteer to help them. It helped everybody. The seniors weren't the passive recipients of visits. They became agents of change in improving the health of their community. They became socially connected and had a sense of purpose. It turns out that having a sense of purpose and meaning is crucial, and that social isolation probably has a worse impact on your health than smoking. So how can we think differently about how we create well-being? The Pathways Community Hub model. Many of you are talking about how you coordinate all the resources, all the services. This is a brilliant model that Mark and Sarah Redding, Dr. Redding was here last week, and then Laura Brennan was actually one of the people who helped create this model from the beginning. This is a way for saying, instead of everyone going and trying to help somebody, let's coordinate the efforts. Let's bring all the information together into a central hub that's neutral. Let's have all the service providers in a community contract with that hub, and the payers contract with that hub. It turned out when they looked into what was happening, the average Medicaid family has between 5 and 15 court care coordinators. Everyone's trying to help them, but just like in Kristen's picture, they're not helping them together. And so the average Medicaid mom might be trying to manage 20 hours of coordinating the coordinators. Does that make sense? So this costs a lot less money because the information comes in, they figure out who someone already has supporting them, and then they refer to that. As they did that, they were able to get breakthrough outcomes. They had a 50% improvement. See that orange bar? It was 13 before and 6.1 after. Greater than 50% improvement in birth outcomes for homeless women, for women in color, I'm sorry. And the cost savings was $3.36 for the first year of life and $5.59 per person for every year after that. It's a huge amount of savings for an entire lifetime of people. One of the opportunities for all of us to come together, and we're partnered with the Surgeon General of the United States, so I'm here to ask for your help. One of the ways we need to come together to build solutions is around prescription opioids and the heroin epidemic. I don't know if that's hit you guys here, but it's a big problem in Revere where I take care of patients. We have young people dying with a 150% increase in the death rate and skyrocketing costs from this. We can't solve this problem unless we all come together to figure out what the solutions are, and so we invite you to join us. At Cambridge Health Alliance, remember that red line I showed you about our prediabetes and diabetes? We realized that we could be a community of solutions too. And we got everybody in the community mobilized to improve health, and saw that the schools could become a major partner with the kids themselves as the ambassadors for health. As we did that, we were able to reduce K-8 obesity rates by 20% when compared with matched accruals and improve healthy behaviors. You've already heard Ashley's picture on the bottom left-hand side. My friend Stephen Thomas looked at his community in Maryland and realized that they couldn't reach the African American community. They said, who does the African American community trust? It turns out they spend a lot of time with their barbers. And they created the Hair Network, a network of barbershops and beauty salons led by Freddie Spry, a barber himself, who had created his barbershop as a way of creating jobs in his community to get people out of drugs and incarceration, the school to prison pipeline in his community. He can count. He says 18. I said, what's 18? He said, 18 people who have jobs with me today who aren't in prison as a result of that. He keeps his metric clear. And Freddie would like to have the hair network that he's built in Baltimore go nationwide. Who are the people, who are the unlikely assets in the community right here in Kershaw that could help you, who have trust in the community? The 100,000 Homes campaign was able to get 105, this is 101,000. They were trying to get 100,000 people housed. They got 105,000 people housed in 3 years. It was 20-fold the rate. In several communities, they've eliminated homelessness. How did they do that? By changing the way, by connecting what we could do in health with housing, by linking the data, by showing the health impact of every single person that was affected by homelessness and prioritizing them based on their risk of a poor health outcome. They made the decision easier and got people placed faster. Because they got people placed faster, they didn't have to have temporary beds anymore. So they got turned those into permanent supportive housing. And the health system worked together to connect the dots. All across the country, people are creating these solutions. What are the kinds of solutions that you'll create here in Kershaw? What can we do together that we couldn't do alone? And how can you add your voice, your ideas, the incredible creativity that's apparent in every step of this meeting to create a healthy community? Will you join us? Thank you.